reason, I think we definitely have achieved already one issue, to have a good communication between all of us. However, I think we'd like to continue just to keep in our time frame a bit. And we want now in the second part to focus also on basic science and basic science activity having an impact on atrial fibrillation research. So the first talk is about biomarkers to refine stroke and bleeding risk, and this is given by Jonas Oldgren from Uppsala in Sweden.
Thank you. It's a pleasure to be here again. It's a very nice meeting. I hope I'm not disappointing you, because I'm not going to discuss basic science. It's definitely clinical implications of basic science. So these are my disclosures. I do not accept personal fees from any company, so that goes to my employer. The background for biomarkers is that we have a lot of papers presenting biomarkers which are associated with underlying pathophysiology, with clinical outcomes and effects of treatments in patients with atrial fibrillation. That goes for myocardial injury markers, cardiovascular stress, myocardial fibrosis, etc. So can we use those biomarkers for refined risk estimation in atrial fibrillation? And to be clinically meaningful, a risk prediction score in AF should not only provide good discrimination and be well calibrated and validated according to contemporary standards, where there are some new standards published in the recent years, but they should preferably also balance the risk of stroke and bleeding, and preferably, if possible, be proven to improve outcome, which to my knowledge have never been done in cardiovascular diseases. So may biomarkers for stroke or bleeding be useful to improve risk prediction beyond the scores which we have based on traditional clinical markers. So one of the biomarker-based risk scores presented some years ago by Dan Singer, and here we have the validation from Singer and Asperg and co-workers, looking at the AHRA risk score where they introduced proteinuria, which perhaps is not a traditional biomarker, but eGFR, a measurement of renal function. So they have PONEs both without prior stroke and PONEs for patients with prior stroke. And they compared risk categories based on previous publications for AHRA, CHANCE-2 score, and CHANCE-VAS score, with better C-indexes for AHRA than the other scores. The ORBIT bleeding score was also published 1.5 years ago, looking at bleeding variables, older age, which is above 74 years, reduced hemoglobin or hematocrit or anemia, and you have the limits for reduced hemoglobin and hematocrit lower down on and also insufficient kidney function. So 2 biomarkers, and with this biomarker-based bleeding risk model, they had better C-indexes than the HASBLED and AHRA bleeding scores. We've also developed biomarker-based scores based on 2 large or even 3 large randomized controlled trials, the Aristotle trial and the RELY trial. We looked at this in a somewhat different way in the ABC score. A stands for age, B for biomarkers, and C for clinical history. We looked at which are really the most important markers. And the left panel shows you the most important markers for risk of stroke, which is, of course, prior stroke or TIA, which we knew which have been known for several years. But the next important markers are NT-proBNP, troponin, and then age. So we introduced those 4 in the ABC stroke risk score. And for bleeding, we have GDF15, which is a new marker, growth differentiation factor, which is associated with inflammation, troponin T, age, hemoglobin, and prior bleeding. So this can be used as a nomogram, and we use these markers, continuous markers, which is important, especially for age. And then we calculate the risk for 1-year risk of bleeding and 3-year risk of bleeding. But in the digital era, which is the focus of this conference, we of course have a calculator, and we are just now working on an implementation to have this integrated with electronic healthcare records throughout the world if someone wants to use them, or for instance in the ESC app if ESC is interested. So, as an example, a 65-year-old male with atrial fibrillation, hypertension, prior stroke, and prior major bleeding, you can easily calculate the Hasbled score and the CHA2DS2-VASc score if you want, but by those markers. But you can also add age, troponin T, BNP, GDF15, and hemoglobin, and calculate the risk in this risk calculator. And everyone has a smartphone, so it's very easy to use continuous markers nowadays. It wasn't possible when the CHADS and CHA2DS2-VASc score were developed. Then we need to calculate by hand. So this is the calibration of ABC stroke score. On the left panel, the Aristotle trial and the stability trial, which was a trial of coronary artery disease, but 1,400 of those patients had atrial fibrillation, half of them not treated with oral anticoagulants. And as you can see, if the risk is in the derivation cohort calculated as less than 1%, the green line annually, and the 1 to 2% blue, and above 2% in the red line, it's overlapping lines for those derivation and validation cohorts. We can also look into different CHA2DS2-VASc categories. And as you see, CHA2DS2-VASc on the left panel, 0 to 1, CHA2DS2-VASc 2, 3, 4, or 5 or above. Even within the patients with CHA2DS2-VASc score 0, 1, this is based on both Rely and Aristotle, so it's 23,000 patients. We can tease out in the lowest risk category patients at higher or lower risk, but not at very high risk, the red line, because we have very few patients in that group, of course, because since they had CHA2DS2-VASc 0 or 1. But look also in the CHA2DS2-VASc 4 category, we can tease out low-risk patients, the green lines, intermediate risk and high-risk patients within those categories. This is the ABC bleeding score, comparing it to other bleeding risk scores in the full cohort and in those patients without a prior bleed. The C statistics is really improved compared to the Hasbled and even better than the Orbit bleeding score. And that goes for the derivation cohort in the Aristotle trial and the validation cohort in the Rely trial. We also looked at the differences between treatment with apixaban and warfarin. As you can see, the risk for bleeding is lower irrespective of the bleeding risk class by the ABC score. So apixaban reduces the bleeding risk compared to warfarin in all risk categories. But the absolute risk reduction is, of course, higher in the highest risk category. Just recently, a week ago, there was a novel risk prediction score from the engaged AF TIMI48 trial. So it's called the TIMI AF score. They looked at net clinical benefit, which is of course important. It's disabling stroke, life-threatening bleeding, and all-cause mortality in the VKA-naive patients from the warfarin arm in the engaged trial. So they developed a 17-point Integris score with age in 2 categories, some other clinical markers, hemoglobin and creatinine, so 2 biomarkers. You might say that this is a difficult score, and I think you're right. What should we do with ejection fraction unknown or non-white race? It's rather difficult to use this score. Nevertheless, they calculated the distribution of the TIMI AF risk score and looked into the effects of edoxaban compared to warfarin in those with low TIMI AF score, intermediate, or high TIMI AF score. And the entire positive effect on net clinical benefit is seen in those with intermediate or higher risk in this risk assessment. But they also point out in the limitations that this score needs to be validated externally before usage. So in conclusion, properly validated and well-calibrated refined risk scores, preferably both for stroke and bleeding risk, and perhaps also mortality, which was discussed before the break, may in the future prove useful as decision support tools for personalization of anticoagulant and other treatment strategies. And these risk scores should preferably be shown to improve outcomes in patients with AF. And just as a teaser, I'll show you that we are going to do such an endeavor in Sweden. So we have this hypothesis for an ABC AF study that treatment strategies based on the ABC risk scores for stroke and bleeding will improve outcomes of patients with AF compared to standard of care. So we have set out to randomize 4,000 patients to ABC score guided treatment versus standard of care and look at treatments, procedures, and also on hard outcomes to prove that a risk score really may improve outcome for our patients. And if we succeed, and if others succeed with implementation of these risk scores, especially based on biomarkers, hopefully we will not have a 2B indication in the next version of the guidelines. So thank you for your attention.
Okay, thank you.